talk about what we do in the clinic when we need to help a patient gain PIP joint extension. And we are limiting this discussion primarily to PIP joint problems. We're leaving the other complex problems for other presentations. Our tradition has been passive range of motion, which can be done manually, or the multiple number of orthoses that we can construct to apply a gentle sustained force to either provide a dynamic force or an adjustable force. Those approaches, however, also provide an element of immobilization. In other words, when the patient's wearing these, there's no active glide of any of the tissue layers. The other disadvantage of this approach is that these are worn intermittently, and when they're removed, the patient usually returns to the pathological pattern. In the PIP joint, it's nearly always MP hyperextension and lack of full PIP extension. These devices only take the joint in one direction. Therefore, there's no balance of motion created. And perhaps these devices provide some constriction, which actually increases edema, rather than distributing pressure and decreasing edema. It's a question of how they're constructed and how they're applied and whether there are tight straps involved. These devices, however, in my clinical experience, can be very useful at the beginning of your treatment time with a patient who has been relatively recently injured. If they're constructed circumferentially, here with a wrap or here with plaster of Paris, it can be a significant assistance in reducing digital edema. Additionally, since the intrinsic muscles which extend the PIP joints are weaker, if the resistance at the PIP joint is reduced, active range of motion is a bit easier to achieve. In my clinical experience, however, the really resistant PIP joint that is no longer acute does not respond to this treatment, and we need to approach it very differently. However, if we have regained PIP joint extension, whether acute or maybe longer since the time of injury, we all flex our interphalangeal joints when we're at rest, and particularly when we're asleep at night. So I do believe there's some legitimacy in maintaining full PIP extension at night so that we maintain a minimum resistance at the PIP joint to active extension. Now, many of us have done blocked exercises. This is a very common therapy intervention. We either block the MP joint in flexion to get better IP extension, or we block the MP joint from flexing to get better interphalangeal joint flexion. But I would like to introduce the idea of active redirection. It's an idea that we already are doing. It's simply blocked exercises, but for a longer period of time. Think about it. If the one significant limitation that a patient has is PIP joint extension, why should that not be the focus during the entire waking hour? Why would you want that to be intermittent and then allow the patient to revert back to the almost claw position? This active redirection, where we're blocking the DIP joint in flexion, actually changes the motion here at the PIP joint. We will look at this in more detail and explain the dynamics of it. But it's a new way of thinking that I would like to introduce to everyone. Now, if we take a PIP joint with stiffness that lacks extension, and this green dotted line is what we would consider normal range of motion, What we normally see is usually early improvement, but then losses, and over time there's improvement. There's an upward trend, but we gain extension, lose flexion, gain flexion, lose extension, and we tend to seesaw back and forth. This can be a laborious process full of many treatment sessions and is often somewhat frustrating. I think there's probably a better way for us to approach this. Flowers and Listeo in 1994 looked at the number of days stiff PIP joints were casted. Those that were casted for 6 days versus 3 days had a total passive range of motion increase that was significantly greater. So they concluded that there was a positive relationship between the time a joint is held at the end of its range and an improvement in passive range of motion. But what is missing for me in this is the active range of motion measurement, because we have all been so frustrated by gaining passive motion, but the patient then having an inability to maintain that actively. We have no proven correlation between an increase in passive and an increase in active. There's just no guarantee.